It's good to see everybody here in person, and we have a growing number joining us online. So it's great to welcome the people online. And today we're very honored to have a special invited Dean's Lecture. As I think most of you in this audience know, these events are typically an opportunity to hear from our newly appointed or promoted professors, but this one is a little bit different. When Len Rubenstein came to the Bloomberg School in 2009, it was not a standard appointment. At the time, Len was an accomplished civil rights lawyer and a global expert on violence against healthcare. He joined our school to deepen our work at the crucial intersection of public health and human rights. Because Len was hired directly into a very senior position at the school, there was never a natural moment for him to give one of these lectures. However, now that Len is getting close to retirement, or so he says he's getting close to retirement, I don't know. But I'm definitely getting ready to wrap up my time as dean. So I knew I wanted to seize this opportunity to give him a little extra work and come and talk to us all. So Len, you almost escaped, but not quite. And we're just thrilled to have you here with us today. Over the past 15 years, Len has been an indispensable member of our faculty here at the Bloomberg School of Public Health. As a distinguished professor of the practice, he brings a new lens and expertise to the work of our Center for Public Health and Human Rights. His understanding of the law and humanitarian settings has propelled the center in its efforts to help some of the world's most disadvantaged people. This is urgent and complex work that often takes place in dangerous settings. The center has pushed back against HIV discrimination in prisons. It has uncovered the violence inflicted by the Assad regime in Syria. It has brought new awareness to the depths of refugee health crises around the world. And these are just a few examples of how the center is defending the rights of vulnerable communities, fighting to give them health, dignity, and autonomy. In these efforts and so many more, Len's expertise has helped his colleagues to better understand international humanitarian law and refugee law and ensure they are used for the greatest impact possible. So today, we have the chance and the honor to hear from Len about his own work on one of the issues that is closest and dearest to his heart, and that is preventing violence against healthcare and healthcare workers in war. Between 2022 and 2023, the number of healthcare workers killed in conflict zones doubled. These are doctors, nurses, ambulance drivers, and pharmacists who are targeted or caught in the crossfire. For far too long, these widespread attacks were not a global health priority, but Len has been a force in bringing these attacks to the fore. He leads the field in researching and advocating for accountability of those who break international humanitarian law. His work is broad and global, addressing crises in Syria, the West Bank and Gaza, Afghanistan, Ukraine, and other parts of the world. He also founded and chairs the Safeguarding Health in Conflict Coalition, a group of 30 organizations working to prevent attacks and end impunity at the global and national levels. Len has been relentless in his efforts, working with WHO and other UN agencies and member states to move beyond lip service to real consequences for individuals and governments who consistently and intentionally attack healthcare facilities and workers during conflict. In fact, it is because of Len's leadership and advocacy that WHO started to report on attacks made on healthcare. Thanks to his ever tenacious and dogged work, we can better understand the scope of the crimes and begin to move towards accountability. Len continues to lead on these efforts and every day builds on the exceptional and distinguished career devoted to advancing peace and justice. And it is no surprise that he has been recognized with prestigious honors, among them the Carl E. Taylor Lifetime Achievement Award from the American Public Health Association. Of course, Len will be the first one to tell you how much work there is still to do. While the world has begun to pay greater attention to threats faced by the healthcare workforce in conflict zones, the violence against them persists. In his book, Perilous Medicine, and I highly recommend it, Len writes that it's because it has become conventional to refer to healthcare workers as heroes, when in fact they don't want to be heroes. But they certainly don't want to be martyrs. In Len's words, they just want to be safe in their work as the law entitles them to be. Len, we are so grateful for all you have done, all you continue to do to defend the rights of those who serve and care for others. So important. And we're so eager to hear from you today about how we can press toward our goals for protection of healthcare workers around the world. Len, thanks so very much for all you've done during your very incredible career. And I know you'll continue on, and we're really anxious to hear from you today. Len?
Wow. Well, thank you, Dean McKenzie, for that incredibly gracious and warm introduction. And it's such a privilege to talk to you. And many of you don't know, today is actually International Human Rights Day. It's the 76th anniversary of the International Declaration of Human Rights. And we actually have something to celebrate with the fall of Bashar al-Assad, who was responsible for killing 200,000 of his own people. And as for me, I never expected to be in the field of public health, never expected especially to be in a school of public health. And frankly, it's kind of remarkable that David Celentano, who was longtime chair of the Department of Epidemiology, agreed to have me, as I had no formal training whatsoever in epidemiology. But here I am, and I had a wonderful run here and so delighted to be here and have had so much support. And Dean McKenzie has also been such a support for our Center for Public Health and Human Rights, as well as my work. Unfortunately, though, my talk is somewhat a grim one. We're in a terrible time of violence against healthcare and wars around the world. And I'll be talking a lot about numbers and studies, but as I think it's really important to see what we're talking about. So I'm going to share two photos in different circumstances that bring home what's at stake. The first is the aftermath of a Russian attack on a maternity hospital in Ukraine. You see the hospital destroyed. And what's so striking about this picture is this pregnant woman, likely about to give birth, on a polka dot pink sheet, anticipating a very happy occasion. And instead, what we see is a complete absence of humanity, suffering, and death. This photo is from Nasser Hospital in southern Gaza, which the Israeli Defense Forces invaded in a ground invasion in February. Most people don't know about this. There were severely sick, very severely wounded patients in the hospital. And they needed to be evacuated to save their lives, especially as water and electricity cut off. But for 2 days, the Israeli Defense Forces denied WHO the opportunity to evacuate them, even assess them, or speak to the hospital director. Finally, 2 days later, they were allowed to evacuate patients. By the time they did, 5 patients had died from lack of oxygen. These kinds of situations don't make the news, but these are repeated hundreds, thousands of times around the world. So I'm going to give you a kind of soup to nuts about this problem. I'm going to review The law and history, very briefly, are efforts to understand the scope of the problem, what the impacts of these attacks are and mitigation strategies, what are the drivers of these attacks, and what's happening on prevention and accountability. So I'll start with law and history, which I call the uncertain embrace of humanity. We start in 1859 with the Battle of Solferino in northern Italy between French and Austrian forces. Hundreds of thousands of troops were involved. There were 40,000 military casualties, most men lying on the field, suffering, thirsty, unattended, no relief. Henri Dunant, whose picture you can see, who is a Swiss humanitarian and businessman, happened upon the battle, actually wanted to talk to Napoleon III on a business proposition, but there he was, and he was appalled at what he saw, that these wounded soldiers were not attended to, and he mobilized the local population to help care for them. After the war, he wrote a book, you see it, The Memory of Solferino, eloquent, passionate, as big a bestseller in Europe as Uncle Tom's Cabin was in the United States at the time. And he said, he was a pacifist. He said, we can't end war, but on the basis of humanity, which he said was the moral sense of the importance of human life, the soldiers should be subject to treatment and care, whatever side they were on. He ended up a founder of the International Committee for the Red Cross and called for volunteers to attend to these soldiers. But if they were going to be attended to, they had to be protected. And that led in 1864 to the first Geneva Convention, whose exclusive focus was on protection of healthcare for the wounded and sick soldiers. The combatants were responsible to collect and care for the wounded of whatever nation they belong, enemy or friend. The obligation was imposed to respect and protect hospitals, including caregivers, including local citizens, and it established what is now the familiar Red Cross emblem. Well, fast forward, let's go now to 1949 in the wake of the Second World War. There were serious limitations of the original Geneva Convention. It applied only to wounded soldiers and sick soldiers. It didn't apply in civil wars. So there were a total rewrite after the Second World War. And it established that civilian hospitals, civilian caregivers were protected. It established that in civil wars, this behavior had to be appropriate. A whole new convention on protection of civilians. But there was one thing it didn't do. It didn't stop or prohibit strategic or carpet bombing. And up on the upper left, you can see Dresden, one of many German cities, and of course, Japanese cities, which were destroyed in Allied bombing. They didn't specifically target healthcare. They didn't specifically target civilians, but neither did they protect them. But the effort to say indiscriminate attacks are prohibited failed. As a result, in the upper right, you see North Korea. Very few people know this. 18 North Korean cities were subject to incendiary bombing. About 1 million people were killed, and an estimated 1,000 hospitals were destroyed. And the bottom is Vietnam. In Vietnam and Cambodia, famously, infamously, the carpet bombing, including use of napalm, killed hundreds of thousands of people. It wasn't until 1977 that this problem was addressed. But it was addressed in what are called additional protocols to the conventions, which are now the law of armed conflict with respect to protection of healthcare and civilians. And you see the first important change was that you must distinguish between civilians and civilian objects and military objects that only attack military ones. And then it imposed affirmative obligations, not only not to attack, but to affirmatively make sure people are protected. The most important one, in my view, is that you must take all feasible precautions in attacks to avoid or at least minimize civilian harm, even if your target's a military one. Similarly, there's a prohibition on imposing collateral damage on civilians, which is disproportionate to the military advantage gained. So you can't bomb an apartment building and kill 100 people and to kill 1 or 2 or 10 members of the enemy forces. Also, if you do attack a hospital because it's being used for military purpose and becomes a military target, you have to demand that the forces that are misusing it cease doing so and only attack if they refuse. Finally, it protected medical ethics, particularly not punishing health workers for complying with their ethical obligations, including treating enemies. So that's where the law stands today. This is called customary international humanitarian law. It's binding on everybody. It doesn't matter whether you've agreed to the Geneva Conventions. It doesn't matter if you're an armed group that can't sign international conventions. This is the law for everyone. At the same time, in this period, the international human rights movement was growing, and documentation of attacks, of violations around the world was proliferating. New groups were formed. And in this photo, you see a young Bob Lawrence, now emeritus professor here at Bloomberg in El Salvador in 1983, investigating the murder and disappearances of health workers and attacks on health facilities. And they wrote a report published in the New England Journal of Medicine. 3 years later, Physicians for Human Rights was founded to establish more documentation on these attacks, among other subjects. And that's how I got into this issue in the mid-1990s when I came there to become director. And there were a number of reports. In fact, when I arrived, this first report on former Yugoslavia had already been written, but they wanted me to go to Sarajevo to release the report. And I carefully read the report, and one story just lives with me. A pediatrician named Esma Zasevic was in the pediatric hospital in Sarajevo. There was a neonatal unit. There were something like 15 babies in incubators, and there were other children there. And the hospital started being shelled, and they had to escape. In fact, the unit was destroyed about 5 minutes after they escaped. They went to the basement of a hospital next door, but because of lack of water and electricity, 9 of the babies died overnight. We also did reports in Kosovo, in Chechnya, and I was part of a delegation during the Second Intifada in Israel, the West Bank, and Gaza. And we continued to do this work, but no one was much paying attention. It wasn't a priority for the human rights movement. The global health movement was really expanding in resources and attention mostly because of the AIDS pandemic, but there was no attention to this issue there. The World Health Organization didn't want to get involved. It even had a safe hospital program, but it only concerned structural issues for hospitals in natural disasters. The academic community was also not interested. A few years ago, we did a systematic review of peer-reviewed literature on this problem, and in 35 years, we found a total of 35 publications, and only 5 before 2010. So this was not on the agenda. And when I left PHR in 2008, I was very fortunate to get a fellowship at the U.S. Institute of Peace. And I decided to spend my time looking more deeply into this problem. What's going on? How much is this happening? What is being done about it? And you can see my conclusion at the bottom of the slide. Attacks on health workers and facilities have become a feature of modern war. For too long, violations have not been adequately reported. Violations, when they are reported, protests are intermittent and perpetrators are rarely held to account. I said 3 things should be done. First, there had to be systematic collection of data. We know this in public health. Without data, you're nowhere. You can't solve any problem unless you understand it. But no one was collecting data, and I said WHO has the capacity and the scope with the country offices to do this. And that would enable the world to know about it. You could develop prevention strategies. You could also use it to develop the political will to do something about it. Second was to have commitments to change military doctrine and practice so that protection of healthcare would be recognized on the ground as well as in rhetoric. And I said accountability was essential. And then I came here to Bloomberg. And, I left the NGO world where I'd spent my career. So you could take me out of the NGO world, but you couldn't take the NGO world out of me. So I said, well, I want to do something about my own recommendations. And felt that the WHO was a major place to begin in systematic data collection. So with some colleagues, we started organizing. We wrote to the Director General. We held events at the World Health Assembly, and we got support from some governments, including our own government, Norway and the European Union and others. And we also started the coalition that Dean McKenzie mentioned. Coincidentally, at the same time, the International Committee of the Red Cross was starting its own initiative called Healthcare in Danger, which had very different objectives. It wasn't talking about WHO data collection or accountability, but pragmatic means to help prevent them. And these are 2 very complementary initiatives and reinforce one another and help move it forward. Well, skipping forward, in 2012, the World Health Assembly did adopt a resolution requiring WHO to engage in systematic collection of data on attacks on healthcare. Unfortunately, there was still resistance within WHO to doing this. There are also methodological problems. So its system was not put in place for 5.5 years until 2018. But in the meanwhile, we felt we had to ourselves figure out ways to collect this data, regardless of what WHO was doing. So we developed a field surveillance tool and validated it in Myanmar with community groups, health groups there, and then put it on an app in Syria. Unfortunately, though, it turned out not to be scalable. Similarly, Physicians for Human Rights started, which I had since left, started an initiative to do very intensive verification of attacks on hospitals in Syria, of which there were ultimately 600. And if you've heard that, 600 plus, if any of you have heard that number, it comes from them. So it was a great project, but it too is not scalable. So finally, the WHO issued its system. But the problem was that the caution of WHO was reflected in what they did. So in order to report, you had to be authorized to report. Well, it's not a great way of collecting data if you restrict who can collect and submit the data. They didn't do any outreach to local or national groups. So it was severe underreporting. And their public reporting on their website, where these charts are from, is completely opaque. They don't tell you where the attack happened. It just tells you the country. So it doesn't even distinguish between the West Bank and Gaza, for example. It doesn't tell you exactly what happened. It says explosive weapons were used, for example, but you don't know if that explosive weapon was a missile or an automatic weapon. You have no idea. And it didn't tell you the perpetrator, even if it was obvious to them. And it didn't even distinguish kidnappings from arrests. And there were political issues too. If you look at the bottom, that's from the surveillance system that they established for Ethiopia in the midst of the war in Tigray, where the whole health system was destroyed and 3 Doctors Without Borders staff were murdered, making worldwide news. And they reported 0 attacks. And that was for political reasons, that there was pressure from Ethiopia not to report. So we in the coalition said we have to do something to get this information out. What we had tried in a scientific way turned out to be too complicated to be generalizable. So our colleague, Insecurity Insight in Geneva, one of our members, had experience in collecting and disseminating data on humanitarian issues. And they developed a sophisticated approach to get sources of data that are reliable, not perfect. And we didn't worry about some of the limitations. We reported all the limitations, but we felt if we could get data that was reasonable, we had confidence in the accuracy, and we could verify it would be an advance. And it started very slowly, but it expanded so that now data comes from the Armed Conflict Location Event Database, from the International Safety Organization, which collects incident reports from international NGOs, the Aid Security Database, and local organizations, Myanmar, Syria, Yemen, Palestine, and others. So we have a variety of sources, and it's not scientific, but we have had no pushback on inaccuracy. We've had pushback on political grounds, but not on errors. I'm sure we've made errors. So we're pretty confident in the data, and this is from 2023, over 2,500 attacks. 2024 will be even worse. That was the highest we ever reported. 2024, we're already past 3,000. And we can show trends too. So here are 2 of our charts. You can see over this 5-year period where explosive weapons were used and where they were used the most, including in places that you didn't even know about, like Myanmar. And you can see in Ukraine, after this horrible first year of the war, it continued, not at the same level, but more than 190 attacks in the second year. And then in civil wars in Africa, what you see is health worker kidnappings. And it's almost a completely different set of countries, not totally, but these are mostly African civil wars. And health workers are kidnapped, sometimes for ransom, sometimes to treat, to demand that they to take them away and bring them to their wounded forces. We also mapped what was going on, and in the upper left, you can see Ukraine with all the many, many red dots. There were 1,700 attacks. There have been already in this war. And most of the red dots are in the east and southeast near the front lines. But you can also see those red dots are all over the country. And that helps support the inferences that this was a strategic move. It wasn't just kind of adjunct to a military campaign. And we can see in Myanmar, where the first year after the military coup in 2021, the violence was mostly arrests. Health workers were at the forefront of the civil disobedience movement, trying to restore democracy, and they were arrested en masse. But then it morphed into a war. And so the map shows that it was the dots are no longer in the urban areas where the health workers were protesting, but now all over the country. So we're pretty not satisfied, but we have confidence that this is helpful, if not perfect. But there's a severe limitation. We did studies in the Central African Republic and the impacts of attacks in 3 prefectures in northeast and eastern CAR, which are embroiled in intense conflict with armed groups. In fact, the government has very little control in these areas. And we had the cooperation of the International Medical Corps, which shared its incident reports with us. And what we found is of the 127 incidents that we found in this 4-year period, 57% of them came from the International Medical Corps and only 13 from Insecurity Insight, which is our source of data for the report. And what that shows is that we need to overcome the resistance of humanitarian organizations, local health providers, and Ministry of Health facilities not to report. There are a lot of reasons they don't report, some okay, some not so okay. But if we're going to get a full picture and do equitable data collection for these conflicts that no one pays attention to in very low resources to country, we need to go there. So let's now move to impacts. Some of the impacts are very well known. The polio eradication campaign had a goal of eradicating polio by the year 2000. Some of you weren't even born. 2000. Why wasn't it met? There were a lot of reasons. One of them, according to WHO, was the killing of community health workers in vaccination campaigns. Frequently, of course, required suspension of campaigns, serious delays, and sometimes kids weren't vaccinated at all. And so in those two countries, polio is still endemic. On the upper right are cholera outbreaks in the world between 2012 and 2017, another WHO chart. And that red line looks like the outline of the chart, but it's not. It's Yemen, with more outbreaks than the rest of the world combined. Why was that? Because the Saudis, in their war against the Houthis in Yemen, bombed water infrastructure. And then I'm sure you could tell what's below. That's Gaza, completely destroyed, hospitals attacked, every single hospital attacked. Only 35% of primary care facilities have been left functioning as of this day. Hospitals attacked multiple times. And the capacity of the health system has just disappeared. And we all often hear about the 44,000 deaths, killings in Gaza. There have been more than 100,000 traumatic injuries. We don't know how many people with those injuries died for lack of care because they bled out, because there were no antibiotics in the hospital for infection control, because there wasn't enough time they didn't have the resources and staff to treat them. We don't even know. 5 years ago, 3 other universities joined us, University of Manchester, University of Geneva, and UC Berkeley, joined us in starting the Researching the Impacts of Attacks on Healthcare initiative, whose mission is to learn more about the impacts of these attacks and also develop methods. And here's our team, and we're doing studies in Afghanistan, Colombia, Central African Republic, Nepal, and support for work in Syria. And in one of the publications from Syria, the framework was how do the attacks affect health systems? And it turned out it affects almost all dimensions of health systems. The health workforce diminishes, people are killed or flee, essential medicines are less available, supply chains are seriously disrupted, clinics, health posts, hospitals are attacked and they lose capacity, and on with huge impacts. But we know from these studies that the impacts are variable. They're variable by income level of the country, resources, how pervasive the attacks are, and other factors. And they even vary within facilities that I'll discuss in a moment. Quality of care, we know, suffers, and the communities, as well as the patients, suffer severe psychological trauma. That is a consistent finding in all the studies. We did a quantitative study in Central African Republic and don't look to me to help you understand this. Natalia Kostanova, who just got a PhD here at Bloomberg, really taught us a lot about how to do this. What it shows is there are three facilities, ABC on the left, and 4 services: outpatient consultations, antenatal care, deliveries, and first measles vaccination. And you can see some differences. The first facility, I don't know if you can see the red line, the dotted line on the video screen, but basically every service shut down right after the attack, and it took a long time for them to recover, and the services recovered at different rates. In the second one, the facility was able to continue reasonably well despite the attacks in all services. And the third one, 3 services showed the same patterns of utilization as before, but first measles vaccination declined to 0 for months until a vaccination campaign, that last box on the right. So we see this variability. And we also looked at 12-month impacts. And this graph is an interrupted time series looking at the proportionate change in consultations, first measles vaccinations, antenatal care, deliveries, and hospitalization. And here, too, you see the incredible variance. The top one, in a year, the health post never recovered. But in the other ones, there are, in some cases, outpatient consultations declined, and some they didn't. Well, from our qualitative work, it appears that they declined either because there's been so much displacement, or more likely, as people reported to us, patients were too afraid to come to a health post. And you can go one by one. I'm not going to go through this, but we can see the variability. We still have a huge amount to do to figure out mortality and morbidity, because the methodological questions are enormous. How do you separate the effects of the war from the attacks? And also because in a lot of these countries, it's impossible to get good data. But we know about other impacts, gender impacts. We know most of the health workers in the world are female. In Colombia, the study showed that what among health workers who were socially disadvantaged in the first place, that the violence exacerbated their pre-existing disadvantages for marginalization, burdens of workplace discrimination, and other factors. We did a study in Afghanistan after the Taliban took over and found that it was a survey, 2 surveys with groups based in Afghanistan, and it found that the women could not safely go to and from work. They were harassed by Taliban police for not having a male escort because they weren't dressed properly in the minds of the police. And some left, but quality of care declined, and patients often didn't come because they had trouble traveling. Then the psychological impacts. There has been no more consistent finding across studies, not only that we did, but in South Sudan, Yemen, Nigeria, and elsewhere, that health workers report enormous psychological impacts. And we even took the title for one of our articles that the psychological wounds are more difficult than physical injuries. They suffer from the stress of and anxiety of worrying about the next attack. They worry about their families. They have huge workloads. They also suffer moral injury, which occurs when you know what needs to be done. You feel an obligation to do it, but you can't do it because of lack of resources or staff or materials. And the statements are just extraordinary. Here are just 2. The hardest and most painful moment to feel that you've let people die because you can't serve all in need. I am subject to constant punishment and self-lashing without interruption. And then there are the ethical challenges they face, which are bear almost no resemblance to the ethical challenges we face in this or any country that's not at war. Wrenching triage where you have two babies, this is a true story, two babies that need emergency surgery. There's their brother or sister, and you only have the resources to treat one. How do you deal with that? Armed groups say, treat our guy first. Then you have these crazy questions. Should you discharge a patient before medically appropriate in order to avoid the possibility of it being caught in attack? Do you rehab a facility or move it to a safe area so that it will be safe, but the people in the community where the hospital was have less access? Then one mitigation strategy is to provide longer regimes of medication, give patients more medication to take home so they don't have to keep coming back to the health facility. But that risks non-adherence, lack of monitoring, and it even could bring about antimicrobial resistance. These are, as it were, endemic to what health workers face in these situations. So let me just turn to mitigation. Mitigation strategies are basically up to providers. There's very little help. Sometimes, like WHO provided generators in Ukraine after the electricity grid has been attacked. In Syria, on the left is a hospital underground. Syrians built hospitals in caves as well. On the right is a picture I took in Ukraine. It's the main beautiful maternity hospital in Kyiv. It's the basement. And it's a beautiful hospital. But when there's an air raid, which is 2, 3, 4 times a week, in the middle of the night, all the patients have to be moved to the basement. Imagine what it's like for the women to have to go through this and for the stresses on the staff to get people to the basement in not very comfortable situations. Other mitigation efforts are led by communities. We've seen this in African conflicts, where communities take an enormous amount of responsibility. They even volunteered to be trained to do medical work, nursing and medical work that they were never trained to do before. There are sometimes this help from international NGOs to host the supplies that the health post might need, but that raises its own concerns about transport. And the real problem is there isn't a lot of outside support. Donors are often reluctant to refund health facilities if they worry that it's going to be attacked again. Some have done much better, others not. So let me turn to the next subject now. We've talked about the scope of the problem, the impacts, mitigation strategies. What is driving these attacks? Why do they take place? There have been a lot of studies by social scientists at factors affecting attacks on civilians in war, not on healthcare, but in civilians, about organization cultures of fighting forces, structural factors in how forces are organized, the objectives of the force. I took a different approach. I wanted to figure out what was driving it. Not from a social science perspective, although I relied a lot on some studies that involved interviews with armed groups. But I wanted to understand the logics of the attacks. That is, what did fighting forces think they could achieve by attacking? And what kind of conceptual framework could be developed? My framework has yet to be fully tested, but it's out there. And all of you students, if you're looking for work, here's something to do. So this was the book that Jean McKenzie mentioned, where I set this out. And here are the logics that I came up with. One is to deny care to enemies. That's a picture of Dr. Hassan Bayev, a Chechen a surgeon who is in the picture saving the life of a notorious Chechen rebel who had stepped on a landmine. For that act, and many others, Russian forces were after him, tried to arrest him. On the other hand, the Chechen forces threatened him with death because he was treating Russians. And we see this all over the place. They don't want their enemies to come back into the fight. The second is strategy of war. I mentioned in Ukraine that attacks on healthcare are often used as a strategy of war to force displacement of populations, to undermine the morale of the population, to put pressure on the government to stop fighting. And we see this we saw that in Syria and other places. Another is tactical advantage. That's a picture from Raqqa, Iraq, where ISIS was fighting Allied forces, and that the hospital had a tower, which ISIS used for its sniper posts. Very convenient. But of course, what that meant is it led to attacks on the hospital. Sometimes the tactical advantage can be taking over a hospital just so your people can be treated, armed groups, troops can be treated. Then what I call recklessness and the logic of convenience. This is for entities that claim to adhere to the law and can cite chapter and verse of how they do it, but in fact show indifference to it and establish procedures which they then don't follow. Now, that's an ambulance. I don't remember if it's in the West Bank or Gaza. In my book, I wrote about the prior wars in Gaza and the attacks on ambulances, and that there was a procedure where the Palestinian Red Crescent, through the ICRC, would contact Israeli forces, get permission. The forces would approve movement, and they'd go in to evacuate the wounded person, and they were nevertheless killed. And we're seeing a lot of that in the war in Gaza now as well. A fifth is a political message to the government. And here I think it's most clear in the Ebola response in the DRC, where there was this massive Ebola response. At the same time, the government was not protecting its citizens from armed groups' depredations. It didn't even have a consistent measles vaccine program. And so community group, and there was massive international response with SUVs all over the place and huge numbers of staff on this one issue. And so there was violence against healthcare as a protest. And that was exacerbated by politicians who ran disinformation campaigns. And so that sparked more violence. So, what do we do about this? This is where I'll end. I found in my book, I looked at 3 potential sources of restraint, and this certainly was not original. One is leadership, that if you have a military that establishes appropriate rules to protect healthcare and you have political leaders saying you must do this, we have good examples where there have been changes in instructions and doctrine and training of soldiers in the field so they know how to protect healthcare. They don't just, it's not a matter of giving them a copy of the Geneva Conventions. How do you do it in a pragmatic way? A second is through domestic activities, reforming laws, holding perpetrators to account through court-martials or otherwise. And importantly, you need international pressures and accountability. You need diplomatic pressures, economic pressures, stop sending weapons to perpetrators, and criminal accountability. And for the first time in 2016, the international community said it was going to do something. A UN Security Council resolution was adopted on protection of healthcare in conflict, the first one ever. And it said You have to reform your laws. You have to reform your military practice. You have to conduct investigations. You have to hold people to account. And if you don't do it, the international community should do it. The Secretary General wrote 10 more pages of recommendations, which I won't go into, but it included not selling arms to perpetrators, which is already in international arms treaties and in domestic laws. Unfortunately, and very distressingly, this resolution has been almost entirely ignored. No reforms, few changes in military practice, never been a prosecution in any international tribunal that focused on attacks on healthcare. And we're now into 30 years of these tribunals. So that's where we are. Great way to end, except that it gets worse. On top of that, the law itself is eroding, and I'll just give you two examples. Counterterrorism law has basically superseded international humanitarian law, because in this country, as in many countries, providing health care to a terrorist is a crime. Now, if you remember what I said back to 1864, you must provide care to whoever the person belongs. Impartiality is a bedrock principle. And this says, no, counterterrorism supersedes protection. Then we have reinterpretations of the law. And although there has been enormous documentation and discussion about Israel's conduct in Gaza, one thing that is missed is that it has promoted a view of these key duties of proportionality, and precaution in attacks that undermine them. And as the International Committee of the Red Cross said, without naming Israel, that these new interpretations are essentially a license to kill. So if I didn't depress you by the prior slide, I've got you now. So where do we go? The first thing to recognize is we've been only at this a short time. This was not on the agenda as internationally as recently as 15 years ago. And it's really 10 years that it's been on anybody's agenda. So we can't give up. And we're seeing a few glimmers. Last month, the WHO, which has been so cautious, signed on to a report, it's in its own name, that said we can't use the prior resolutions and rhetoric. That's not enough. We must develop a new alliance of governments and UN agencies and civil society that are really going to commit to this, including, and WHO said this, lobbying the International Criminal Court to prosecute perpetrators. At the same time, last month, not the same time, but last month as well, there was a commentary in The Lancet which included the president of the National Academy of Medicine, the executive director of the American Public Health Association, the head of the International Council of Nurses, among others, that said professional groups and the public health community must get out of its comfort zone about not taking political positions. And that comfort zone has been very powerful, or lack of comfort has been very powerful, because there's even self-censorship about talking about Gaza, for example. So these organizations in this community must take stand, including, for example, calling for stopping arms sales to perpetrators. This is professional associations. Dean, I know this is going to be a problem, but this is what needs to happen. And it's really about mobilizing opinion, putting pressure on governments to do these kind of things. And I'm going to close with one final thought. People ask me how I do this very depressing work, see all this violence, see all this suffering. And the reason I really do it is because I've met so many health workers around the world who don't have the luxury not to engage and who have inspired me. I'll just name 5 of them. The top left, you've already met, Dr. Bayev from Chechnya. Next is Dr. Shebnem Finkanci, a forensic pathologist who was actually called an enemy of the state in Turkey for truthfully reporting on torture of prisoners and attacks on healthcare. Next is Luan Yaha from Kosovo, who was imprisoned for allegedly providing care to an enemy and since became a human rights activist. The bottom left is Dr. Pierre Samse, who is currently Minister of Health of the Central African Republic, who has not only been a leader in seeking to protect healthcare, but on one occasion put his life on the line by stopping an attack on a hospital. And finally, it's Dr. Iyaz, the late Dr. Iyaz Siraj, a Gazan psychiatrist and founder of the Gaza Community Mental Health Center, who was a human rights activist and also a psychiatrist who understands the deep psychological impacts of the violence in Gaza on children as well as adults, and worked so hard to address it. So I just want to end with some thanks. I've had so many collaborators and supporters. These are people from Bloomberg. And Joe Amon on the upper left just joined us, although he's been working with me on this issue for much more than a decade. And on the bottom are students. And just want to point out, the second from the left is Dr. Mohammed Darwish from Syria, who is actually a political prisoner there. And the students were first authors on many of our publications. Natalia, who I mentioned, is the 4th from the left, and next to her is Jen O'Keefe, who worked so hard on that project, co-first author, and Diana Reyes, who also got her PhD recently and did most of the work on Syria. And so these have been great supporters of this work. And I'm not going to make you read this, but there are so many others who have been collaborators and supporters to try to address this seemingly intractable problem. Thank you.
Thank you so very much. Incredible job of chronicling all the great work you've done over the years. And I was going to ask the question you ended with. I'm sitting there thinking, how can you persevere and how can you keep going and how can you have hope? Because I know in my personal interactions with you, you are a very hopeful person and a very forward-looking person. But it must be just so very, very difficult in the area that you're working in. But you answered the question in part at the end.
I'll just say one more thing for students. People say, are you optimistic? And my answer is, you don't need to be optimistic. You just have to do. And that's how you achieve something.
Well, we do have a few minutes for some questions, either here in the audience and those of you online. If you have a question, just type it in the chat and we'll call on you. Go ahead. Oh, here we go.
I'm Dr. Mumini from Burkina Faso, and your presentation is just amazing. While I'm talking here, we lost one of my colleagues a few days ago from the attack of Djibo. And the problem is, I'm a medical doctor, and many people in my country are not even trained to know what to do in this context. If you receive a terrorist, you don't treat him, you will be in danger. where you live and where you work. And again, I tried to even see the statistics, the data about how many healthcare are attacked, etc. And I don't have access to it. But I asked those information as the director of community health of the Minister of Health, but I couldn't get it because of the political situation. So do you have any strategy to get those informations available so decision can be made about them? And are you aware of any trainings that my people can get to know how to better, cope with this situation? Thank you so much.
Well, thank you for all you do. It's Burkina Faso, like Central African Republic, is in a tough place, very poor country, and subjected to this terrible violence. A simple answer is in the reports that we issue every year that I showed, there is a country section on Burkina Faso. And like Central African Republic, we know it's severely underreported, but I can get in touch with me and you can get not only get the report, but you get it in French. So you know something. And then perhaps networks can develop to help get more data out. As far as training, one of the great things the international community, the Red Cross, which I'm sure is in Burkina Faso does, is train health workers on coping strategies and responses. So I hope I'm right that they're present there, and it's worth taking advantage of them because they are committed to this.
Okay, so then in the aftermath of October 7th, Richard Morton, the editor-in-chief of The Lancet, the highly prestigious medical journal, penned an editorial in which he recalls his time in Gaza, walking into health facilities and seeing the pictures of terrorists hanging on the wall. This editorial precipitated the end of the Lancet Palestine Alliance. It was widely seen as stoking anti-Palestinian racism and attacks against healthcare. And we've seen in the year after unrelenting, unceasing attacks against the Palestinian healthcare system. And a lot of the arguments that have been used to justify this have been grounded in legal, in laws, in legal arguments. And so I ask you this question because I know you're both a lawyer, but you're also an ethicist. And what I'm feeling, and I don't know if this is correct, but what I'm feeling is that what is legal is not always what is moral or what is ethical. And so I just wanted to hear your reaction to that.
It's a great question, and it comes up all the time. I only briefly touched on this. I think actually the law on this is morally grounded in an important way. Hospitals, for example, are protected. But if it becomes a place to fire weapons like from Raqqa Hospital, it loses protection. The important thing, though, is that's not the end of the story. The fact that some group is using a hospital illegally doesn't give the attacker to destroy the entire building. In fact, it's the opposite. The obligation is to keep medical services functioning. At Nasser Hospital, to continue this, they didn't do this. The whole intensive care unit was knocked out. And not only that, they arrested and beat many of the staff. So you don't have to, which the law says you can't do. So I see the law here as helpful. What's not helpful, and people might not like this, is when they say a hospital is a sanctuary. That is, no matter what happens, you can't touch it. That's not helpful, not only because it doesn't reflect the reality, but it's not helpful in that we'll never get some public support for such a position. But I think the law here is excellent. It's not followed, which is the problem. And there's no accountability for it. In fact, how did I learn about what was going on inside Nasser Hospital? I wasn't there. I looked at the WHO Twitter feed, X feed, where they said what was going on. And for what they said, the Israeli government said that they were complicit with Hamas. So it's a fraught issue. But I think if we educate ourselves, and not just ourselves, but our governments, about what the rules really are and how it's morally grounded, and you don't have to give up self-defense by obeying the law, we'll be in a much better place. Hope that's helpful.
Other questions, comments? All right, well, with that, Len, let me again thank you so very much for everything you continue to do. We're just so fortunate to have you here at the Bloomberg School, but even more so, we're so fortunate to have you in the field of public health. And you're transitioning into public health as a lawyer is just phenomenal. So thank you for all you do, and thank you for providing us with an outstanding lecture today.
And thank you for coming.